Hi, this is Susan Panter. Today I'm going to be sharing with you about Cardiovascular Review and Hemodynamics, and this is for our course number 2244 in nursing. The cardiovascular system includes the heart and its blood vessels. It supplies oxygen to organs and other body tissues. When diseases or other problems occur, oxygen and perfusion decrease. Also, it can result in or increase with life-threatening events. The cardiovascular system works with the respiratory and the hematological systems. Workload increases if problems with these systems occur. Fun fact or not so fun fact. Cardiovascular disease is the #1 cause of death in the United States. There's an average of 1 death every 40 seconds. Diseases such as coronary artery disease, including myocardial infarction and cardiomyopathy, congestive heart failure, atherosclerosis, hypertension, peripheral vascular disease, and pulmonary hypertension, which leads to cardiomyopathy, are all things that fall in this category. In your readings, one of the chapter talks about the anatomy and physiology or a cardiovascular assessment, so make sure you kind of look over that, especially the high points. But let's look at the anatomy right now. We're going to be identifying normal blood flow through the heart and also taking a glance at the heart. The normal blood flow through the heart begins on the right side. Deoxygenated blood from the veins enter the right atrium on the right side of the heart through the superior and inferior vena cava. Blood flows through the tricuspid valve into the right ventricle. The right ventricle pumps the blood through the pulmonary artery into the lungs for gaseous exchange at the alveolar and capillary membranes. Freshly oxygenated blood is picked up in the lungs, returns to the heart via the pulmonary veins into the left atrium. Blood flows through the mitral valve into the left ventricle, and then blood flows through the aorta to be pumped into the systemic circulation. And here's a great diagram of the heart. You'll notice on the right side, at the top and the bottom, you'll see a superior and inferior vena cava. This is where the blood begins the blood flow. You see the 4 chambers of the heart, atrium and a ventricle on the right, and an atrium and a ventricle on the left. The lungs are not visible here, but there is a pulmonary artery that leads to the lungs, and the pulmonary vein leads back to the heart. The aorta, you'll see the aortic arch at the top, and also at the bottom, you'll see the aorta, and that leads the blood directly to the body. More fun facts. Each heartbeat pumps approximately 60 milliliters of blood. That's 5 liters per minute. And during strenuous physical activity, it can double. So what makes the heart work? Electrophysiological properties such as automaticity, excitability, conductivity, contractility, and refractoriness are the properties that we're going to be discussing. Automaticity is the ability of a cell to initiate an impulse spontaneously and repetitively. Excitability is the ability of a cell to respond to a stimulus by initiating an impulse, such as depolarization. Conductivity is the ability of a cell to transmit an electrical stimulus from cell membrane to cell membrane. Contractility is the ability of a cell to contract in response to an impulse. And refractoriness is insensitive to immediate stimulation that develops irritability. So looking a little deeper in the cardiac conduction system pathway, we have an SA node or a sinoatrial node, an AV node or an atrioventricular node, a bundle of His, bundle branches, right and left, and Purkinje fibers that wrap around the bottom of the heart. The cardiac conduction system is diagrammed here for you. You'll notice that the SA node, which is the pacemaker of the heart, is located at the right top of the atrium. The atrioventricular node is located at the bottom of the atrium. The bundle of His starts at the septum and it branches off into a right and a left bundle branch, and then the Purkinje fibers wrap all the way around the bottom of the heart or the ventricles to help with the completion of the electrical conduction pathway. If the SA node does not fire, which it normally would fire at 60 to 100 beats per minute, if it does not fire, the AV node will take over. AV node will not take over at 60 to 100 beats per minute, but more like 40 to 60 beats per minute. The body cannot sustain life at 40 to 60 beats per minute. In fact, the heart will wear out if it's only beating 40 beats per minute. So that kind of gives you an idea the importance of a healthy cardiac conduction system. With electrical impulse, a sequence of events occur for a beating heart. I probably should have flipped this around and put systole on the top because we're kind of used to that being our top number, and diastole on the bottom. But systole is a contraction and the emptying of the atria and ventricles, and diastole is a relaxation and filling of the atria and the ventricles with the changing pressure and volumes. The heart rate is the number of times the ventricles contract each minute. An average adult has 60 to 100 beats per minute. It is controlled by the autonomic nervous system, or the ANS. The ANS is broken down into the parasympathetic and the sympathetic nervous system. Parasympathetic nervous system is responsible for slowing the heartbeat. In fact, the vagus nerve, if you've heard of a vagal response, we will have a problem with dropping of our pulse and dropping of our blood pressure. The sympathetic nervous system increases the heart rate. So you can see things on here like epinephrine and norepinephrine, which are catecholamines. They do increase heart rate and increase contractility. And many of the cardiovascular drugs we administer to our patients actually will block this fight or flight response or pattern and decrease our heart rate to a more healthy rate. The function of the arterial system is to deliver oxygen and nutrients to various body tissues. At the tissue level, nutrients, chemicals, and body defense substances are distributed and exchanged for cellular waste product depending on the need of the tissue. Arteries transport cellular waste to the kidneys and to the lungs to be reprocessed and removed. The blood pressure is determined primarily by the quantity of blood flow or the cardiac output, as well as the resistance in the arterioles. So our blood pressure actually equals cardiac output times peripheral vascular resistance. The regulation of blood pressure is controlled by the autonomic nervous system. It either excites or inhibits the sympathetic nervous system. They kind of work on what we would say like a teeter-totter, depending on what the body's needs are. Baroreceptors will decrease blood pressure and chemoreceptors will increase blood pressure. The kidneys will sense a change in blood flow and activate what is called the renin-angiotensin-aldosterone mechanism. It tells the body whether to retain sodium and water. It tells the body we need vasoconstriction to occur. It also tells the body to release antidiuretic hormone if needed. Endocrine release various hormones to stimulate the sympathetic nervous system, again, such as catecholamines, which are epinephrine, norepinephrine, and dopamine. The kinins, which are inflammatory mediators, which are formed in the body in response to injury, which cause vasodilation and smooth muscle contraction. Serotonin, and also histamines. Normal blood pressure ranges, systolic will be from 90 to 130, diastolic 60 to 90. So again, 90 to 130 over 60 to 90. Depending on which reference book you look at or which physician you are working with, you may need to see numbers vary just a little bit. Remember that systolic is the peak pressure during ventricular contraction, and diastolic is the lowest pressure during a ventricular relaxation. Mean arterial pressure is considered to be the perfusion pressure seen by organs in the body. It is known as MAP. It is believed that the MAP of greater than 60 millimeters of mercury is enough to sustain the organs of an average person under most conditions. If the MAP falls significantly below this number for an appreciable time, the end organ will not get enough blood flow and will become ischemic. How do we figure our MAP? It is 2 times the diastolic plus systolic divided by 3. So if I were to give you a patient that had a blood pressure of 120 over 80, you're going to take 80 times 2, which is 160, plus 120, and get 280. Divide that by 3, and you're going to have a mean arterial pressure of greater than 90. If we had a blood pressure of 85 over 40, you're going to take 85 or 40 times 2, which is 80. 80 plus 85 is 165, and then you're going to divide that by 3, and you're going to get a mean arterial pressure of 55. So you can see our second reading, we had a mean arterial pressure of less than adequate, so that patient is going to be at high risk for tissue ischemia. And as a nurse in an ICU area, we need to do something for that patient, or we're going to be seeing a problem with our patient. Now, which number is important or most important? They are all important. So when we are looking at our systolic blood pressure, it tells us how hard the heart is working. When we look at the diastolic blood pressure, it looks at how much the heart is resting. And when we look at the mean arterial pressure, we're asking how well is our heart perfusing. So you can see that it's important for our heart to work well with a good pumping action. It's important for our heart to rest well so that it can have good filling time and also doesn't get wore out. And then our mean arterial pressure, again, if it's not perfusing well, we're not getting enough oxygen and nutrients to all of the tissue. The function of the venous system is to complete the circulation of blood by returning the blood from the capillaries to the right side of the heart. Hemodynamic monitoring is the use of an invasive system to evaluate the function and performance of the heart. It directly measures the pressures inside of the heart and the great vessels. It is used in the critical care areas by the critical care nurses, and it provides a quantitative information or a number about vascular capacity, blood volume, pump effectiveness, and tissue perfusion. So why do we need hemodynamic monitoring? It will help with early detection, identification, and treatment of life-threatening conditions. It will evaluate our patient's immediate response to treatment, such as medications and mechanical support, and it will also evaluate the effectiveness of our cardiovascular function. When would we use hemodynamic monitoring? Patients that have decreased cardiac output from things like dehydration, hemorrhage, or GI bleed, burns, or surgery. We'll also use it with all types of shock, such as septic, cardiogenic, neurogenic, and anaphylactic shock, and also with any deficit or loss of cardiac function, such as acute MI, cardiomyopathy, and congestive heart failure. This diagram just shows the cardiac cycle with the EKG in relationship to the pressures in the aorta and also the left atrium and left ventricle. Our blood pressure on here is 120/80. And if you'll just look at the top and the bottom of the diagram where the aorta is, that's where you get those numbers. The left atrium and the left ventricle are under 10. So I'm going to guess probably about 5 for the left atrium and 2.5 for the left ventricle. And you can see how they work with the EKG strip. Mechanical properties of the heart include the cardiac output, cardiac index, heart rate, stroke volume, preload, and afterload, and we're going to be discussing all of these. Other terms for hemodynamic include stroke volume, central venous pressure, pulmonary artery pressure, or systolic and diastolic blood pressure in the heart, pulmonary artery wedge pressure, venous oxygen saturation, and the ejection fraction. Let's look at the cardiac output first. It's the amount of blood ejected from the ventricle in 1 minute. The normal range will be from 4 to 7 liters per minute. So our cardiac output is figured by the heart rate times the stroke volume. Our cardiac index is taking the cardiac output and adjusting for a person's weight and size. Cardiac index will equal the cardiac output by the body surface area. A normal range is going to be 2.7 to 3.2 liters per minute. So if I were to give you a client number 1, we're just going to say a female client. Their height is 5'5", their weight is 160. If you were to get onto a body surface area calculator, they would figure at a 1.82 meters squared body surface area. So then you take, we're going to say they have a cardiac output of 5. So if you take their cardiac output of 5 and you divide the 1.8 body surface area into that, you're going to come out with a cardiac index of 2.7. And you can see that's at a normal range, at a low normal range, but we're definitely perfusing enough with that. If we took client number 2, 5 foot 9 inches, 200-pound patient, and I told you that the body surface area calculated out to a 2.1 meters squared, you're going to take 2.1 and divide it into our 5, which I told you that was the cardiac output we were going to use. That comes out to 2.4 cardiac index. That number is significantly lower than the normal range. Therefore, that patient would be at high risk for poor perfusion. The heart rate we know is how often the heart beats in 1 minute. It works with the stroke volume, and there are compensatory mechanisms. With tachycardia, the heart can't fill as fast, and we lose cardiac output. Things like supraventricular tachycardia, atrial fibrillation, rapid ventricular rate, and sinus tachycardia are issues that happen with that. With bradycardia, the heart has time to fill, but the pump is not adequate to perfuse to the rest of the body. Thus, we lose cardiac output. With dysrhythmias, the heart has an ineffective electrical conduction and ineffective pumping, and we will also lose cardiac output with that particular situation. The stroke volume is the amount of blood ejected by the left ventricle during each contraction. If the stroke volume is up and the heart rate is up, we're going to have a good cardiac output. It's going to be up. However, if the stroke volume is down and our heart rate is down, our cardiac output is also going to be down. Thus, poor perfusion. The right and left ventricle eject the same amount, and the stroke volume and the ejection fraction are mirrors of each other. A normal range is going to be 60 to 80%. Greater than 60%, they say, is adequate. Remember, the lower the ejection fraction, the poorer the heart muscle and the pump is. Stroke volume is also determined by the preload, afterload, and contractility, and we're going to look at each one of those individually. The preload is the degree of myocardial fiber stretch at the end of diastole and just before contraction. It's determined by the amount of blood returning to the heart from both the venous system to the right heart and the pulmonary system, the left heart, or the ventricular end diastolic volume. Frank Starling is a gentleman who studied the heart, and he says the more the heart is filled within its limits during diastole, the more forceful it contracts, which makes sense. So what I want you to do is visualize the filling of a balloon. If we have good fiber stretch versus poor fiber stretch. So preload is the amount of blood in the ventricle before it contracts or ejects. Think of it as filling pressures. It also is diastole, so it's as the heart is filling back up before it contracts again. So I want you to think, how full is the balloon and how full is the tank? Afterload is the resistance the blood in the ventricle must overcome to force the valves open and eject contents into the circulation. How hard the heart has to push to get the blood out is resistance. So let's think about our balloon again. If we blow our balloon up and I hang on to the top of the balloon and I don't tie it, I just let go of my balloon, the balloon is going to go flying through the air and the air is going to come out of the balloon fairly easy. However, if I fill my balloon up and I don't tie it off again, but this time instead of just letting it go, I hang on to the top of the balloon and I pull the opening of the balloon, I stretch it apart, it makes that squeaky noise. How hard does it have to work then? It has to work pretty hard. So that's what I want you to think of with the heart. If we have good healthy valves, the heart is going to pump the blood through nice and easy. We're not going to have a high afterload. We're not going to have problems with that resistance. However, if we have valves that are stenosed or damaged muscle, we're going to have a heart that has to work a lot harder to get that blood pumped from one area to the other. So think of your balloon every time we think of the afterload. Afterload is determined by vascular resistance or the pressures in the pipe, and think about whether it's dilated versus constricted. Our heart doesn't have to work near as hard if the vessels are dilated than it does if they're constricted. Also think about the ability of the heart tissue to contract adequately. If we don't have good adequate contractions, then we're going to have problems with that. Also, oxygen level can play a role. Hypoxemia can cause vasoconstriction. So we have compensatory limits. Our stroke volume will decrease due to a decreased filling time. So with a normal heart, compensation will occur with a heart rate greater than 180. With a diseased heart, compensation will occur with a heart rate greater than 120. We'll see increased heart rate, increasing myocardial consumption. We'll see increased heart rate, decreasing coronary blood flow, and less filling time. So our stroke volume increases due to bradycardia, compensates for high cardiac output and high blood pressure as seen within athletes. That's a normal thing with an athlete to have a low blood or a low heart rate, whereas if we had an elderly patient with a low heart rate, they're not perfusing like they need to. Dysrhythmias is another thing that the stroke volume has to increase with. We have a loss of sync of the atria and the ventricles, and we can lose 20 to 30% of our cardiac output with a dysrhythmia. Fast rhythms such as uncontrolled AFib, junctional tachycardia, SVT, VTach, atrial tachycardia. Also, slower rhythms like with junctional rhythms and heart block, and idioventricular rhythms. Contractility is another thing, how well the ventricle walls move. So I want you to go back and think about your balloon. Think about how well does the balloon stretch and then go back to its original size. With a healthy heart, the heart will stretch with each filling and contraction, and then it goes right back to the normal size with filling again. With a diseased heart, however, contractility is not as good. So think about our balloon. If we blow the balloon up one time, the balloon goes right back to the original size if we let the air out. But if I blow that same balloon up 100 times, eventually the elasticity of the balloon becomes more of a flabby balloon, and it does not carry the same shape as it did prior to blowing it up. So contractility decreases due to infarction, cardiomyopathy, vagal stimulation, and hypoxia. Okay, so remember I told you that stroke volume and ejection fractions kind of mirror one another. Ejection fraction is the ratio of the volume of blood that is ejected from the left ventricle with each beat to the volume of blood left in the left ventricle at the end of diastole, also known as left ventricular end diastole volume. An indication of the systolic performance of the left ventricle as a pump. That is what the ejection fraction tells us. So a normal ejection fraction in an adult is 60 to 80%. So if you are on a unit and the doctor tells you the heart is only working 20%, they're talking about the ejection fraction. That means the heart is not working well. The higher the ejection fraction number is, the better the heart function is. The lower the ejection fraction is, the more support the heart needs from medications or whatever in order to help sustain and perfuse the body. So with things like severe congestive heart failure, our ejection fraction is extremely low, and fluid is going to just sit in the body or the periphery and third space because we don't have a good, strong enough heart muscle to pump that blood back where it needs to go. So some factors that cause a low cardiac output, if we look at inadequate left ventricular filling, that can be caused from tachycardia, rhythm disturbances, hypovolemia, stenosis of the mitral and tricuspid valves, stenosis of the pulmonic valve, constrictive pericarditis or tamponade, and restrictive cardiomyopathy. With inadequate left ventricular ejection, problems that can cause that would be coronary artery disease, myocarditis, cardiomyopathy, hypertension, aortic stenosis, mitral regurgitation, drugs that are negative inotropins, and metabolic disorders. So I want you to think about why these disorders cause a low cardiac output, whether it's the heart's beating too fast, not allowing the heart to fill completely, or whether we have a rhythm disturbance that doesn't allow the pump to fully contract all the blood out of the heart. So critical care nurses are going to monitor our systolic and diastolic blood pressure, mean arterial pressure, central venous pressure, cardiac output and cardiac index, pulmonary artery pressure. Pulmonary artery wedge pressure is actually going to be done by the physician, but that's a number that's important to the critical care nurses also, and the systemic vascular resistance. Readings are going to be recorded approximately every 1 to 4 hours. The main thing is focusing on trending. Just like we do with our lab, they're going to be trending their hemodynamic monitoring to see what is working, what isn't working, what did they do, what did they not do, and how are their numbers changing. Central venous pressure, or CVP, are pressures within the superior vena cava and reflect the pressures under which the blood is returned to the right atrium. It measures the amount of fluid in the circulatory system. So when we have low CVPs, it indicates a reduced blood volume. When we have high CVPs, it indicates circulatory overload. CVP often is identified as right atrial pressure. And as you can see, our numbers here, less than 2 indicate hypovolemia, and we must consider fluids. If we have 2 to 6, it's adequate volumes, and if we have greater than 6, hypervolemic is considered, and we must think about giving diuretics. Pulmonary artery wedge pressure is the measure of the blood pressure in the main pulmonary artery. So we check peripheral blood pressures. This actually is measuring the blood pressure directly in the heart. So pulmonary artery systolic numbers should be 20 to 30. Pulmonary artery diastolic will be 8 to 12, and pulmonary artery mean pressure 25. Pulmonary artery wedge pressure is also known as pulmonary artery occlusive pressure. This is a measurement that reflects left atrial pressures. And like I mentioned earlier, the doctor, anesthesiologist, or CRNAs will be the one that check these pressures. A balloon is blown up inside the pulmonary artery. That balloon is kind of like a balloon that's on a Foley catheter, but it is on the pulmonary artery catheter, or the Swan-Ganz, and it will actually measure the pressures of the left atrium. Mixed venous oxygen saturation indicates the balance between our oxygen supply and our oxygen demand. So low levels will indicate hypoxia, which you know. If we don't have enough blood to oxygenate our organs, we will see poor organ perfusion. High levels can also indicate situations like sepsis. So our range for this is going to be somewhere between 60 and 80. Invasive hemodynamic monitoring is done through an arterial line, also known as an ART line or an A line. It is a catheter that's placed into an artery, such as a femoral, brachial, or radial artery. Catheter is connected to a pressure tubing. IV bag is hung of normal saline, and a pressure bag is going to be put around that to hold the pressure at about 300 millimeters of mercury. That will help maintain patency of the line. It's going to be connected to a cable and then connected to a display monitor, which will give us our readings. In this case, we do have to zero the system out before we get any readings, and that way we know that it is level. Kind of like a scale, you always make sure it will balance on 0 before you put a patient on and weigh them. It's going to be level to the plebostatic axis, and we have our axis, and we have a picture in the next slide or so. And then when we do a waveform test, it actually will make a square waveform, and that's going to validate accuracy of our ART line. In order for an ART line to be accurate, blood should be able to be drawn from it. It can be zeroed. It's connected to a 300 millimeter flush bag, and also you can obtain a normal square waveform test. Those are going to tell you that it is good to go. Cuff pressure is never as accurate as what arterial pressure is. So again, if we are to measure a patient's blood pressure in the arm, it's not going to be near as accurate as if we measure the atrial pressures in the heart through an arterial line. ART lines are not used for IV fluid administration, and also monitor circulation of the limb, such as capillary refill, temperature, and the color, to make sure that it's not compromised in any way. Here's a picture of an A line or an ART line. Again, just to stress to you, it looks like a regular IV catheter here, so you just need to understand that it is not used for any medications. If we use medications on it, it can be life-threatening, so it is used only for monitoring. And here's a diagram of what it would look like on our patient. You'll notice that there's an art line in the radial artery here. It's hooked to the pressure tubing, the transducer, and then that is also attached to the monitor, which shows our waveforms. This picture is just a picture showing you of what a waveform might look like. You have the systolic uptake, you have a dicrotic notch, and then you have the diastolic runoff. If you'll notice, the top of the systolic comes to about 120, the bottom comes to 180. So the waveform is going to correlate with your heart rate. The peak is the systolic number. In this case, it's 120. You have the dicrotic notches, which represent the valves opening and closing. And then you have the end wave, which equals the diastolic number, which here it's 80. Pulmonary artery catheters, or Swan-Ganz, are another type of catheter that is inserted in order to monitor hemodynamics of a patient. The catheter is inserted into a large vein. It's threaded through the right atria and the ventricle into a branch of the pulmonary artery. Pulmonary artery catheters have multiple lumens, ports, and components that allow hemodynamic monitoring, except atrial blood pressure, or arterial blood pressure, I should say, blood sampling, and also infusion of IV fluids. So the large veins that they're going to use here will be brachial, femoral, subclavian, and internal jugular veins. If you go to edwards.com, they have a little video clip, real short video clip of insertion of a Swan-Ganz into the heart. You can actually see where the tip of the heart moves from the right atrium to the right ventricle all the way up into the pulmonary artery. The functions of a pulmonary artery catheter allow for continuous bedside monitoring of vascular tone, myocardial contractility, fluid balance. They can all be assessed and managed through those numbers. It also measures pulmonary artery pressure, central venous pressure, and allows for hemodynamic calculated values. It measures cardiac output and cardiac index, also SVO2 monitoring, and fluid administration. A description of the pulmonary artery catheter ports and lumens. They have blue, yellow, white, red, and then some miscellaneous ports. The blue port is for central venous pressure monitoring. It's the proximal port. It measures the right atrial or the central venous pressures. When the ICU nurses say we're going to shoot numbers, this is typically the port that the numbers come from. This is the port that has the infusion IV bag hooked to the pressure bag, and also you can obtain some blood samples through this port. The yellow port is the PA distal port. It measures pulmonary artery pressures. It can also check pulmonary artery wedge pressures, and it measures mixed venous oxygen, or SVO2. Our white balloon inflation port is our VIP port. This is the port that the nurses use. So remember, nurses wear white in the olden days, and the white port is the one we use. This is the port and the only port that we want to infuse fluids and also administer medications to. The nurses need to deflate and also make sure that it is in a locked position when it's not used. The red port is like a temperature port. It tells us the difference between temperatures in the right atrium and the pulmonary arteries in order to determine the cardiac output. Here's a picture of a pulmonary artery catheter. Notice that it has the 5 lumens. I've just kind of diagrammed the color of each one of these lumens. The other thing is I want you to recognize that they have markings on the catheter. Each thin line is 10 centimeters. Each thick line is 50 centimeters. This is just a good indicator of how far the catheter is in the patient. So once the catheter gets put into the patient, you'll notice where the marking is at so that we know how far it is in, so that we can notice if it has been migrated out or migrated into the patient further than where it needs to. If that balloon at the end that you see on the catheter is not in the correct spot, it can cause dysrhythmias. So let's say it slid back into the left ventricle, it's not in the pulmonary artery anymore, we can start having dysrhythmias in that area. So that's why it's important for us to note that. And here's a picture of the Swan-Ganz also. The other thing you'll notice on this one, it has a special port on it, the square blue one that does continuous cardiac output and also SpO2 monitoring. It hooks up to the monitor. Here's just another picture of a hemodynamic setup. So pre-procedure for nursing, we need to make sure we obtain an informed consent. We are going to assemble the monitoring system, make sure the air is purged from the system and that it is primed, maintain sterility of all connections. We need to get the patient placed in a supine or Trendelenburg position. We'll be administering sedation and pain medication as prescribed. The level of the transducer needs to be equal with the plebiscitic access, which corresponds with the right atrium. That's the fourth intercostal space, mid-axillary line. We'll make a mark there. And when we have our guest speaker next week, he'll teach us a little bit more about that. Remember, we have to zero the system with atmospheric pressure before we can obtain any readings. And then we're going to compare our mean arterial pressure with our non-invasive blood pressure readings. Then we will document the client's response. Inter-procedure monitoring for alterations. Preload problems, we're going to be looking at things again. With the right heart, we're going to look at the central venous pressure. The left heart, it's going to be the pulmonary artery wedge pressure, but again, that's going to be done by the physicians. If our volumes are elevated, we're going to note signs and symptoms like crackles in the lungs, jugular vein distension, hepatomegaly, peripheral edema, and taut skin turgor. If it's decreased or we have low volumes, we're going to see poor skin turgor and dry mucous membranes. With afterload, the right heart, we're going to note the peripheral vascular resistance, and on the left heart, it's going to be systemic vascular resistance. With elevated pressures, we're going to see cool extremities, weak peripheral pulses, and with low pressures, when they're decreased, we're going to see warm extremities and bounding peripheral pulses. Post-procedure actions. Obtain a chest x-ray is going to confirm our catheter placement. We're going to continuously monitor respiratory and cardiovascular status, looking at our vital signs, our heart rhythm and our rate, our respiratory effort and the pattern, and also compare our non-invasive blood pressure readings to our arterial blood pressure readings. We're going to maintain line patency and integrity, monitoring and documenting the waveforms. We need to report any changes to the provider because if we see changes in the waveforms, this can mean, again, that our catheter has migrated or displaced. We're going to document the catheter placement each shift and also after movement for any kind of transport or repositioning. We will monitor and secure connections between the pressure tubing transducers and catheter ports. Readings are going to be obtained as prescribed. We need to make sure the patient is in supine position prior to a reading. The head of the bed can be elevated to 15 to 30 degrees, but we have to take into account then our transducer and the zeroing of everything. So we will let Micah tell us a little bit more about that next week. This is the plebostatic reference point, so it just gives you an idea of how it is measured. The one thing I forgot to mention on the slide prior, when we look at our readings, we are looking at trending. So trending is so very important. Just like when we look at our lab values, one lab value won't tell you much, but when you start looking at the trending of lab values, it paints you a good picture of what your patient is like. So trending is important with our hemodynamic numbers also. This just shows us that anytime we change positions on our patient, we need to re-level the transducer to make sure we have accurate readings. If we have a reference system 1 centimeter above the left atrium, it's going to decrease our pressures by 0.73 millimeters of mercury. If we have referencing the system 1 centimeter below the atrium, it's going to increase our pressures by 0.73 millimeters of mercury. And again, we will have that explained a little bit better next week. These are the waveforms that you're going to see as a pulmonary artery catheter is introduced into the heart. You'll notice the first picture, the balloon is right there in the right atrium. I want you to ignore the numbers on this screen. The main thing that I'm looking at is showing you what the waveform looks like as it passes through that particular area. As it passes through the ventricle, it almost looks like a PVC, a real wide waveform. The third picture is actually the wave pattern that we want to see. That is where the tip of the catheter is right at the pulmonary artery. So we're going to see that upsweep or the systolic uptake, the dicrotic notch, and then the diastolic runoff. So that's what we want to see in a normal waveform. If the catheter migrates too far into the heart, you will see that fourth pattern show up. So a fun fact, pulmonary artery occlusive pressure or wedge pressure safety points. We're going to watch the monitor during inflation, and the provider will stop when they see the pulmonary artery occlusive waveform. Never inject more than 1.5 milliliters of air or any fluid into the PA port. Don't keep the balloon inflated longer than 15 seconds. So as a nurse, we're just watching the clock to make sure the doctor keeps that under the 15 seconds. And when complete, we want to make sure that we allow the air to passively exit the balloon. Not only can we have arrhythmias as complications of a PA catheter, but infection and sepsis. So it's important that we pick up on infection early so it doesn't turn into sepsis. We want to make sure that we are using good hand washing, dressing changes per protocol, monitoring our white blood count for elevations and also temperature elevations. Specimen collections. If we do suspect an infection, we need to get blood cultures, and we also need to send the tip of the catheter in for a culture to the lab. So if there's a potential that it is an infection from the PA catheter, they're going to remove that catheter, and then we'll take the tip of that catheter out. Pulmonary embolism is another thing. So flushing the line with normal saline per protocol prior. Avoid introduction of air in the line. Recognize that there's a risk for pneumothorax during an insertion, so we need to be monitoring that patient for any problems of dyspnea, shortness of breath, increased anxiety, uneven chest expansion, and also recognize that there is always a risk of dysrhythmias during the insertion and the removal of the catheter. This slide just kind of shows you about what we would do for issues with preload, afterload, contractility, or heart rate. So if we have the following, then this is what we're going to do. That's how I want you to read this. If we have hypovolemia as a part of our preload, then we're going to be looking at things like giving packed red blood cells, albumin, or normal saline, decreasing the amount of diuretics, and decreasing ACE inhibitors. All of those things will help with hypovolemia. If we have venous dilation, then we're going to be looking at things like increasing nitroglycerin and calcium channel blockers, dobutamine, and morphine. With low contractility or the forcefulness of the heart contraction, we'll look at decreasing calcium channel blockers, increasing digoxin, which will actually help with contraction, increasing dopamine and dobutamine, and increasing milorone. With low heart rate, we're going to look at decreasing beta blockers and calcium channel blockers and increasing atropine, dobutamine, and dopamine. With afterload, we're looking at requiring to open up the aortic valve and eject blood or the resistance flow to the arteries. So things like increasing dopamine, decreasing ACE inhibitors, nipride, decreasing calcium channel blockers, and decreasing beta blockers will also help with our afterload. I know this slide has a lot of information on it. As we go through the semester and start talking about some of these, hopefully they will make more sense to you. Assessment findings for decreased cardiac output. We'll note variations in blood pressure, tachycardia or bradycardia, cool mottled extremities, delayed capillary refill, weak thready pulses, jugular vein distension, dysrhythmias, fatigue, weakness, dyspnea, orthopnea, tachypnea, rails, and altered level of consciousness. Those are the things that we're going to be watching for on our patients that have potential for or are in process of decreased cardiac output. So the bottom line, a healthy cardiovascular system yields good tissue for perfusion. If our clients have poor cardiovascular system, their nurse must perform thorough assessments, perform focused assessments as needed, understand hemodynamic monitoring, understand what the numbers mean, know when to call the doctor, know what treatment to anticipate, and pay attention to the details. Again, this isn't something that's going to come overnight. Cardiovascular nurses have had to be trained in this and have had to study before they ever felt comfortable being able to understand the numbers that they're reading. So this is just a basic overview. If you have some questions about anything in particular, I want you to write those questions down, and next week when we have guest speaker, they can maybe help us understand some of these things that are a little confusing to us a little better.